Hospital and Harvard. Itamar and I have been very excited to have Franklin join us. So I'm just going to read a little bit from his bio just to introduce him, and then Franklin, I'll just pass it over to you if you want to fill in any gaps.
Sure.
And kick it off. So Franklin is a graduate of the University of Massachusetts Medical School, after which he completed residency in adult psychiatry at the MGH/McLean program. He completed post-residency fellowships both at MGH in consult liaison psychiatry and a research fellowship at the Cardiac Psychiatry Research Center. Dr. King has practiced in a variety of clinical roles at MGH, including the Neuropsychiatry Clinic, Adult Outpatient Clinic, and the Center for Anxiety and Traumatic Stress Disorders Clinical and Research Program at the Avery Weissman Psychiatric Consult Service and the Acute Psychiatry Service. He's held a long-term interest in bringing the benefits of psychedelic-assisted therapies to patients that are currently left inadequately treated by existing and available psychiatric interventions, and is currently the Director of Training and Education at the Center for Neuroscience and Psychedelics, in which role he is actively involved in educational projects to clinician groups and residents on psychedelics and psychedelic-assisted therapy. Dr. King is also a principal investigator and co-investigator on studies involving psilocybin-assisted therapy and MDMA-assisted therapy, respectively, at MGH. Okay. Franklin, I'll pass that over to you in case there's anything you want to add to that, and take it away.
Sure. So thanks for having me. I'm glad to be here. Yeah, I mean, I need to start shortening that intro, because when you work at a place as big as MGH, you know, you accumulate these long lists of alphabet soup things that you've done and worked at. But the gist is, I'm from Boston. I trained at Mass General. I work there now. I work clinically, and I'm also involved in research. But, you know, my main interest, and let me just share my slides, actually. Hold on, I'm not actually, oh yeah, share screen. So I'm on a computer I haven't been on in a little while. All right, so really the main area of interest that drives me within psychedelics, I think, is really an interest in maintaining really kind of the fidelity of what I think psychedelics actually have to offer. All right, and the purpose of this talk, this is going to be a little bit freewheeling and go into a little bit of political philosophy and a little bit of clinical commentary. But really the main area that I think is crucially important in psychedelics today is figuring out how psychedelics are actually going to fit into a medical model that is quite alien to everything that psychedelics stand for. And there's a lot of different directions that we could go with this. I'm just going to sort of pick a smattering and dilettantish fashion of a few. But I think really trying to think deeply about that now, rather than just sort of assuming that the field is going to figure it out on the fly, is what we need in psychedelic medicine right now. And secondly, I think as a byproduct, there is a great deal that medical practice could learn, not just from psychedelics specifically, but rather from the key paradigms by which we conceive of how psychedelic assisted therapy works. I think there's a lot that the medical profession and the medical model could stand to benefit from actually learning how to conduct psychedelic assisted therapy and some of the underlying philosophy for that. So that's what I'm going to talk to you about today. And first off is really just defining the problem. So, you know, it's just amazing to me. I started medical school in 2009. I would never be talking about psychedelics. I didn't get to talk about psychedelics. Nobody even mentioned them. When I was in medical school, even when I started residency in 2013, I was very cautious to mention that I was interested in researching psychedelics. And things have changed quite dramatically, right? And so here I am giving you all a talk on psychedelics. You're all in the medical world. I'm a psychiatrist up here in Boston. And I think we need to just pause and think about why that is, right? So psychedelics are probably perhaps the most demonized substance through the mid part of the 20th century. There was a massive amount of propaganda, both from the federal government, but also from our own medical profession, on how dangerous psychedelics were. And yet today it's almost impossible to look at a newspaper without seeing something touting the benefits of these things that were demonized only 10, 15 years ago. And so this is a really dramatic change. And the question is why? Why is society suddenly so willing to be considering that which it previously and only recently was demonizing? And to do that, I think we need to be honest about our profession. And when I say our profession, I usually give this talk or similar talks to psychiatrists and psychiatric trainees. But thinking about where we're at as a field. So this data is a little bit out of date, but you can find almost any chart that will show the same thing up to contemporary times in 2023. We are in the midst of a massive mental health crisis in this country. There are rising rates of depression. We are seeing suicide increasing year after year. Overdose deaths in particular have been skyrocketing since the pandemic. These numbers, again, have continued to rise, but the percentage of teenagers taking antidepressants, taking antipsychotics, people taking medications for anxiety are increasing across all classes, from benzos to antipsychotics, as well as for sleep aids. There was a CDC report that came out about 3 weeks ago showing 10% of Americans were taking something to go to sleep at night every single night, and about a fifth were taking medication regularly to sleep. Okay. So we are in the midst of a crisis. We're in the midst of a mental health crisis. And despite the fact that some of the crisis is driven by lack of access, that's only part of the story, right? So we actually are seeing increasing rates of both diagnosis and treatment in psychiatry across the whole. And yet this is not putting a dent in this tsunami of mental health suffering that we're seeing. And so we're really kind of at a point where we're in a standstill of conventional drug research, right? So if I were a psychiatrist who were 50 or 60 years old, I would have done my residency during the heyday of psychopharmacology of the 1980s and 1990s, the Prozac revolution. People thought we were going to, quote unquote, solve mental health. We were going to have a medication for every disorder, that by this point, that psychiatry would be treating every single patient that came through the door. And there was a lot of exuberance and excitement. And that really has that wave has crashed and receded at this point. And there's really actually very little in the way of even drug development research, right? So most of big pharma, aside from psychedelics at this point, has really pulled back on psychiatric research. And so we're kind of in the midst of this situation where we have more and more people taking medications. We have more and more people getting psychiatric diagnoses. We have less and less research aimed at actually addressing this issue. And this is kind of the lay of the land. And I think we need to be honest about the fact that this is the lay of the land. And that really is fueling, in large part, I think, a desperation. And when you get a desperate situation, you have people become far more willing to think of something totally and radically different. And that is the fertile ground in which psychedelics have come back as an area of intense focus right now. And so I think, on the one hand, it's a very good thing that we're able to talk about psychedelics, that we're looking at psychedelics. I myself do believe that psychedelics do offer to radically change the mental health care system if certain things happen. But there is a risk. Whenever people are in crisis, people are vulnerable. And the degree of hype is of great concern. There's a ton of money flying around in psychedelics. Whenever there's a lot of investment, people should be wary of where that's going and what that means. And people love talking about a paradigm shift, but will the paradigm actually shift? Or could we wind up just with another version of what we're seeing now, but with very expensive psychedelic clinics? So my interest is in figuring out how can we ensure the safe, equitable, and the most effective re-entry, I say, of psychedelics into our society. And as a corollary, what can we as a healthcare profession, particularly psychiatry, potentially learn from psychedelics and learn about psychedelic-assisted psychotherapy? All right, so the key problem transcends the mental health crisis. And before I go to the next slide, I am not here to convert you to any particular political philosophy, but there is no doubt that the key and fundamental driving factor fueling the crisis that we are seeing in medicine and in psychiatry is capitalism. And so I want to deviate a little bit and talk just a bit about some core tenets of Marxist philosophy. And before you run away screaming, I am not a Marxist, I am not a communist. I was a humanities major in college. And really what I find Marxism, or some of the tenets of Marxism, to be so helpful for is a really intense intellectual way of scrutinizing the ills of any given society. I think that was what Karl Marx, in a long line of great sociologists, really can teach us, a sort of a specific form of a magnifying glass to look at certain social ills without necessarily trying to convert anybody into a particular way of politically thinking. So some of these tenets are very relevant to issues that we are facing in psychiatry today, as well as psychedelics. The first is the concept of alienation. And alienation originally simply meant this process that started occurring during the Industrial Revolution, where people up until that point would actually see the fruit of their labor, that you would work all day on a product, that you would finish the product, you'd hold it in your hands, and you would go sell it directly. And with the industrialization of society, the worker started becoming alienated from the actual product. People were going into factories, you yourself as an individual would produce one part of a product, and then it would go on the assembly line, and you wouldn't even see the finished product. So that was the original meaning of alienation, but it also grew in the 20th century from a sociological angle to talk about this tendency within our system to start really eroding the lateral bonds that connect people, sort of the destruction of community, the destruction of horizontal social ties, and an increased focus on sort of hierarchical top-down control. Now, for those of you that work in a healthcare system, this is exactly what we have been watching happen since the 1970s. There is a great increase in the sort of hierarchization and industrialization of healthcare. And this process is related to the objectification of the worker, right? Where in a different way of looking at things, each person might be considered unique. But in a large-scale industrial society, there is this sort of tendency that we need to be mindful of, where people can become replaceable because we think of them as objects. And in the modern healthcare system, this is exactly what tends to happen. And this is exactly the patient experience that a lot of people complain about, that they feel like it's a factory line, that they're coming in, that rather than the physician sitting down with them and really understanding them as a subject, and that their subjective experience matters, that they're really just sort of seen as a thing or an object to be moved down the assembly line. And so, and there's obviously reasons for this, and we're not going to come down and talk about subjective experience with every single patient that comes through for a kidney issue or for a gastroenterology issue, but this is particularly relevant for psychiatry, and especially in psychedelics. And I say this because the system is oriented towards an objectifying way of looking at things, for better or worse, and yet psychedelics cannot be boiled down into any sort of objectified way. One person's psychedelic experience is never going to come close to another person's psychedelic experience. This is very true in therapy. And the thing that is first and foremost so difficult about figuring out how the heck we're going to get psychedelic assisted therapy into the medical model is the role of the subjective experience is so crucial. And yet we can't divide and conquer that up into a series of ones and zeros. Okay, so I'll come back to that in a minute. The second is this idea of reification, which really is more of a sort of critical theory concept from the 1920s to the 1950s that a lot of social philosophers were talking about. The term technically means the act of treating something that is only an abstraction as if it were a concrete object. And so from a political standpoint, it refers to this tendency to accept a given reality as if it were the true reality. All right, so nowhere is this more true than in things like the economy or in money. Money is something that we consider to be real. It obviously is, in a sense, real to us, but money is not intrinsically real. It's only real because the economy is actually the sum total of millions upon millions of individual human decisions to make it so. Okay, it is different than the laws of physics or the laws of nature or the laws of biology, and yet we attribute a degree of reality to the economy or to money in a manner that suggests that we are essentially taking it as the actual reality. And so the beauty of understanding this, and this is what the Marxists were after in the earlier part of the 20th century, is that by sort of dispelling the illusion of things that are not actually real, but are simply reified creations, that people can develop class consciousness and sort of discover the power of what they really are. I'm less interested in that, but I am interested in how reification operates in psychiatric patients. People do reify, people who are depressed, people who are anxiety, people who have anxiety, people who have trauma, they tend to reify their suffering into these realities. And a really interesting way of thinking about how psychedelics seem to work is that they allow people to kind of de-reify their lives, right? They sort of come out of a psychedelic experience and they sort of realize that all the things that they'd sort of seen as being these things that they themselves could never change, that were immutable in their lives, were actually constructions of their own mind. And so this is sort of a tool. This is one way in which psychedelics seem to work and seem to help people. So I think it's an interesting way of thinking about things. For those that are in psychiatry or interested in psychiatry, the idea of reification more in terms of sort of treating psychiatric diagnoses as if they have a validity that is equally as real as something physical. This is far and away not a fringe character. This is Stephen Hyman, who is one of the most widely published psychiatrists probably in the world. He's here at Harvard as well. And he wrote this excellent paper looking at the problem of reification from a psychiatric diagnostic standpoint. Really good paper that kind of explores some of these issues. But back to the situation in medicine. So where we're at right now is we have a problem really of commodification in medicine. And this has been something that really has increased quite significantly over the last several decades. Jacob Stegenga, who I highly recommend looking up his work, writes extensively on this. But really, what we're looking at with commodification is that we have a tendency in medicine to focus on the aspects of disease that are the most easily separated from the whole patient. All right, so this is obviously in some ways a good thing, but it's taken on an extreme, I would argue, where we're only looking at the things that can be categorized and isolated. And we end up separating diagnoses and treatments from the actual full reality of the patient. And the byproduct of this is that basically diagnostic tests and medical treatments, i.e. drugs, turn into commodities, that we sort of have commodified medicine to the point where rather than actually looking at the whole person, that we are essentially treating medicine as if it were an economic enterprise and medications become the commodities. So this has been widely described in the United States, particularly, in some countries in Western Europe are not immune to this. There is a really concerning increase in just medical treatment generally. This isn't limited to psychiatry. People are getting more and more medical tests, and they're taking more and more medications, and it doesn't seem to correlate with any benefit in actual health outcomes. Be that as it may, this is the way our medical system works. And so the question becomes, is it possible to commodify psychedelics? Is this something that we actually want to do? Or is this really a weakness in our system that's going to make it difficult to figure out how we're going to implement psychedelic assisted therapy? So the issues are not just economic. Some of the underpinning philosophies of our culture are really going all the way back to the Enlightenment. This is sort of critical theory 101, so forgive me if there's any humanities majors in the audience here, but I'm quoting Theodore Adorno, who wrote extensively in the 1940s through 60s, wrote about some of the sort of the philosophical underpinnings of our culture and how they harm the individual. And in this quote, he's talking about science, where he's saying, bourgeois society is ruled by equivalence. It makes the dissimilar comparable by reducing it to abstract quantities. To the Enlightenment, that which does not reduce to numbers and ultimately to the one becomes illusion. All right, now that is a little bit dense, even though it's a short quote and a little bit obscure. But essentially what he is describing is a tendency in science for us to just simply say, if you can't write it out in a data spreadsheet, then it's not even real, okay? And this is, again, one of the issues that we butt up against in psychedelic research, where there are so many concepts that come up for participants that are impossible to reduce to a measure. We have things like the mystical experience questionnaire, the altered states of consciousness scale, and these are attempts at quantifying the psychedelic experience in numerical fashion. But anyone who's doing this work, or anyone who's been through any of these studies, knows that that doesn't come close to actually capturing the full breadth of what's actually going on. And so it's not denigrating the need to have objective reality and to put numbers to certain things, but our system is so addicted to looking only at that which is quantifiable in numbers that it really gives us a significant blind spot, I think, to understanding how psychedelics are working and how we really might actually maximize their benefit as we eventually get them through the approval process. So, there's a lot of critics out there. I'm not necessarily one of them on the potential risks of medicalized psychedelics for these reasons. And, I definitely think that psychedelics have a great deal of promise, and in either case, they are certainly moving in a direction of medicalization. So that's the reality that we all have to grapple with. But I think just thinking about some of these issues up front before they get FDA approval is really crucial to do in the next few years. So just being aware of the fact that we do have a medical commodification system, and we see the kind of the classic commodities type language. You go on Twitter, you see all of the researchers talking about receptor precision, right? I mean, this sounds very much like the articles that you might read in 1990 when Prozac and Zoloft were coming out. At that time, they were thinking, we're going to have a different SSRI for every single psychiatric disorder. Now there's this talk, we're going to have precise psychedelics. We're going to have a different form of psilocybin for every psychiatric condition. There's a lot of research going on. Do we even need this pesky psychedelic effect, which is so inconvenient for physicians to have to deal with? So why don't we just figure out 5-HT2A receptor agonists that don't even have a psychedelic effect? Novel psychedelic agents, despite the fact that we have millions of unstudied psychedelics developed by people like Alexander Shulgin sitting out there, they just simply can't be patented. And rather than the focus on the things that those of us who work in this field know are really the key points of how psychedelics are helping people, things like connectedness, transcendence, spirituality, even if we dare talk about that in medicine. But these are the things that are much more difficult to break down and put on a spreadsheet, right? So there are some limitations here. So I think a lot of people are interested in psychedelics because they are quote unquote disruptive. We love talking about disruption, and psychedelics are so disruptive. And some people who are probably overly exuberant about psychedelics speak about this idea of psychedelics being a Trojan horse, right? It's sort of, we're aware of all these problems in the system, but we think that all we have to do are get psychedelics into the system, and then they're just going to magically disrupt everything and fix the medical system and fix all of these issues that we have. And I think that's a very dangerous way of thinking. And it's a way of thinking that is unfortunately prevalent primarily only on the private side of many psychedelic researchers. But it's a thinking that essentially absolves us of the responsibility of actually calling attention to the inadequacies of the system now. And it's kind of a form of what we might call a spiritual bypass, which is where we sort of are assuming that psychedelics are going to just do the work for us. But the work that needs to change the system that I'm talking about here is only going to be done by human beings. It's not going to be done by any drug, even if it's a psychedelic. So this is a sort of a medical cultural issue. And it's not just my own opinion. Tassin Noorani, whose quote I cited there, wrote extensively about this. It's a really excellent and provocative paper called Containment Matters, published in 2021. He was working at Johns Hopkins at the time. But he essentially talks about that there's a sort of secret hope in a lot of psychedelic researchers that psychedelics are going to rectify psychiatry's over-embrace of acontextual drug-based remedies. That is just sort of looking at people as serotonin receptors and nothing more, and sort of bring things back in a direction that's a little bit more psychotherapy oriented. So I think it's worth talking about this out loud rather than making assumptions. I'm going to shift a little bit and speak about how we actually approach knowledge and whose knowledge is valuable. All right, for those of you in the audience who are medical students, I think it's very important just to ask yourself how you actually determine what knowledge is valuable, how you actually weight knowledge, how you rank it, and why you do that. Okay, so this quote is from Alexander Shulgin, who was a famed and much beloved psychedelic researcher. He's responsible for first determining the effects of MDMA. He developed and synthesized hundreds of novel psychedelic agents. And he wrote this towards the end of his life in a book. You'll find the phrase, "That's not good science," used time and again when someone runs an experiment and comes up with a conclusion that you disagree with. You'll say, "That wasn't good science. It wasn't done in a double-blind system. It was a preliminary study that doesn't have any value." Marvelous euphemisms for throwing out other people's results that don't agree with your philosophies. Okay, so we can use knowledge as a weapon. And within the contemporary discourse and the field of psychedelic research, there's often a ton of criticism levied at the studies because of the inability to successfully conduct a double-blinded study. Conducting psychedelic research, it's impossible to blind. It's very obvious to almost everyone who's been given the placebo versus the actual psychedelic. It tends to be very obvious to the psychotherapists who are sitting with the patient as well. And I would suggest that we are a little bit overly hung up on being addicted to the randomized controlled trial that's double-blinded as being the sole source of information that is valuable. And this is an issue that is coming up in psychedelic research, because if you can't conduct blinding, and if only the results of studies that are successfully blinded are those that can give us information that we can actually utilize and value, how are we to actually study psychedelics at all in such a situation? So this is a challenge. I want to go a little bit deeper and speak about this issue, which is a sort of growing concept, which has been called the cognitive empire, or just neocolonialism by another name. All right, and this is sort of the empire of knowledge. And we are all presumably in the United States here, so we are all, from a knowledge standpoint, we are in a very privileged position. But the vast majority of both access to as well as dissemination of knowledge comes from a very small slice of the world's population, primarily from the US, Canada, Australia, and Western Europe. So vastly overrepresented in any measure that you look at. So I've shown here a distribution of internet domain names, average number of Wikipedia edits, but this is true not necessarily for all scientific papers, but for the most highly cited papers, they almost always come from the Euro-American West. And so 75% of the world's population is vastly underrepresented in access to, as well as participation in the creation of knowledge and the sharing of knowledge. And why am I talking about this? I'm talking about this because I want to introduce this concept of epistemic injustice, which, for those of you that are not familiar with epistemic injustice, refers to the devaluation of another person or another group's capacity for being a source of reason or information due to prejudice or bias. This is relevant if you're going into medicine, because this is not just important, obviously, for all marginalized communities, but this is particularly important for certain patient populations, especially for psychiatric patients and for PWUD, which is people who use drugs. And when you're in a clinical setting, again, when I ask you, how do you determine whose knowledge is real? There is a tendency to really devalue the information of patients as being someone who has a capacity of being a knower, of being a capacity to transmit information. Somebody comes in, and if you know that they're a psychiatric patient, there tends to be a devaluation of them as a source of information. And this is also particularly relevant for psychedelics, in the sense that traditional and indigenous uses of psychedelics have been going on for thousands of years, right? So everybody knows that there's been indigenous peoples in North and South America who have been using mescaline, have been using ayahuasca, who've been using psilocybin for thousands of years. And yet nature is not publishing the opinions of shamans and community leaders who have been working with these tools. And this is understandable. These were not scientific studies, but it's not a question of acknowledgement. It's a question of, is that information less valuable than the information from a randomized control trial? So these authors, for those that are interested in this, did a very deep dive into the issue of epistemic injustice in ayahuasca research. And essentially the gist of this paper is that they discuss the fact that a study in Sao Paulo, Brazil, that used freeze-dried, semi-synthetic ayahuasca that was delivered in a hospital unit, essentially by psychiatrists, the fact that it was a double-blinded study with only 20 participants, that the data, the knowledge from that study is instantly deemed far more valuable than anything that anyone who has wisdom or collective experience using psychedelics in the so-called field might have, right? And so that all of this indigenous knowledge and wisdom is devalued from an epistemic standpoint, that we don't actually take it as something worthwhile in terms of how we might actually be guiding the emerging field of psychedelic medicine. We don't even talk to indigenous practitioners who really ought to have the most know-how in this, and really probably the greatest right to these medicines as tools. This is another paper. This is a far shorter one and a little bit more provocative. Dr. Macmillan is a psychiatrist and a bioethicist in Australia. And he writes about issues of epistemic injustice in psychedelic research, where he says, really from a bioethical standpoint, if there is any sort of major novel treatment that's going to be brought into medicine, that it is ethically right to speak to those who are stakeholders in this, and that really that not consulting groups of people that have an extensive history of using psychedelics is actually unethical, that we're sort of ignoring a lot of information that from an ethical standpoint could actually potentially prevent harm as we seek to bring these into the modern medical world. It's a very provocative paper. It's only 3 pages. Highly suggest reading it. All right, and then what about the epistemic status of psychedelic experiences? So by that I'm asking, is there anything of epistemic value? Is the knowledge actually real? Is it valuable in any way? What people actually gain from psychedelic experiences? Is it just a healing experience, or are the insights true? So this is a rich area of philosophical discussion, but I think it's worth just sort of considering that from a medical standpoint, we have no idea what to do with this, right? So I think whether we overtly believe it or not, the tendency in the medical framework is, again, that if you can't sort of divide and conquer and put it down on a spreadsheet, then it really isn't real. And so we have no idea how to interpret these experiences that patients are having. And this is because this is from Sarah Ritchie, who is a philosophical researcher in Scotland. She writes of this insidious influence of a totalizing physicalism that reduces extraordinary conscious experiences to neurological events. And I think there is also a tendency, you see this in the New York Times as much as you see it in peer-reviewed literature, to look at the neuroimaging rather than look at the qualitative reports, right? So we look at by how much did the Hamilton Depression Rating Scale drop in a psychedelic study. That gets published in Nature. The qualitative reports were summaries of people describing how they felt they changed and what the content of their experiences were. That's an ancillary article, and that gets published in a much lower profile journal. And so what is it about that? And are we missing something? Should we be paying more attention to the actual experience itself to figure out, how we're going to actually implement these things? If there's something that we could learn that would be helpful for patients if we appreciated this more. So I think it's worthy of consideration. This here is a quote by Huston Smith, who was a comparative religions scholar here at MIT across the river from where I am now for many years, really influential guy who periodically was interested in psychedelics as well. And he wrote this in a commentary in the very first of all of the Johns Hopkins studies that was published in 2006. He was impressed at the results, and he wrote, however, he says, in the end, it's altered traits, not altered states, that matter. Okay. That psychedelics ultimately are not going to do all that much if they simply enact a state change, because the state changes, but the trait doesn't. People are going to find themselves right back where they were eventually. So he says, by their fruits shall ye know them. It's good to learn that volunteers having even this limited experience had lasting benefits, but human history suggests that without a social vessel to hold the wine of revelation, it tends to dribble away. That's the next research question, it seems to me. What conditions of community and practice best help people to hold on to what comes to them in those moments of revelation, converting it into abiding light in their own lives? Okay, and I think this is the stuff that we need to be thinking about now. How can we foster ongoing integration of the benefits, or as Smith calls it, the revelations of psychedelic experiences, to really foster over time changes in traits, rather than simply looking at, how quickly did the MADRS for depression drop? It's a depression rating scale. So one way that he articulates is talking about building communities to hold these experiences, groups of people, community level and social level, things that can foster integration. And I think another thing that we need to think about, and this is connected to one of my areas of research, is building practices that can sustain psychedelic insights. Is the therapy that we're giving enough now, or are there more practice-oriented ways of approaching psychedelics, something more like contemplative practice, meditation, that might actually catalyze greater insights as well as sustain the revelations that people experience? So I think we need to be thinking about this now, particularly given the cost upfront of 1 or 2 sessions of psychedelic assisted therapy. So one way I think that we could do this is thinking about psychedelics not as a treatment per se, because I think that has a lot of limitations, but rather thinking about psychedelics as a practice and a praxis of psychedelics, the sort of the union of theory and action is praxis, right? So you sort of teach people a framework to understand, you teach people skills, and then they combine them, and that's praxis. And so what are the actual practices that can actually sustain the changes? And thinking about psychedelics more as a tool for ongoing healing and growth, I think is probably a better model than thinking of them as a treatment per se. These are quite different from going into a psychiatrist's office and getting a prescription for sertraline. And I think perhaps changing our focus, which is quite prevalent in our society, from hedonia, which in Greek refers specifically not just to the seeking of pleasure, but also to the avoidance of pain, to the superior philosophical concept of eudaimonia, which really is more oriented towards human flourishing, would be a paradigm that would be useful to approach psychedelics by. Thinking of these things that William James called the fruits for life. Okay, James referred to the fruits for life in terms of the benefits from mystical experiences generally. He was not talking about psychedelics per se, but things like profound sense of love, awareness of beauty, emerging wisdom, that I would call for these things to really be front and center. These should be the things that we should be prioritizing here as we move forward in this field. And finally, what can the health professions learn from this? How in the world can we possibly develop a language and a facility with things like this? So I think one of the issues stemming back, both to the sort of devaluation of the subject and the objectification that we see in healthcare, is this is something that really currently affects both patients and healthcare practitioners, right? That essentially personal experience in healthcare generally tends to be devalued as anecdotal information. And so, somebody could be practicing clinically for 6 years and they could tell you this as a medical student, but if they tell you that and then you read something different and up to date, that up to date is always going to be deemed superior. Now, I'm not making a plea to throw out evidence-based medicine, but the extreme degree to which we ignore personal experience and wisdom in the practice of medicine, I think is having a corrosive effect. And I think this also impacts patients, right? That we, again, tend to not appreciate the subjective experience of the patient. We're looking at parts of the patient. We're creating distance between ourselves and the patient. And so the way that the paradigm of psychedelic assisted therapy works, subjective experience is elevated, and the role of the physician is not interventionist. The role of the physician, or of the therapist rather, is to simply sit with the patient as they're having their experience. And I think that that is a paradigm that could help us all as we move into a different form of psychiatric practice in the future. And so while there's so much work going on right now, finding out how the heck we're going to basically modify psychedelics to fit a system that is really foreign to them, I think it might be worth considering accommodating psychedelics in how the system might actually benefit by being a system that would be a better nest to absorb psychedelics as they are. We're spending an awful lot of work fighting against psychedelics to make them accommodate this, to make them fit into the system. And I think we should do it a little bit the other way around. And I think doing this really is going to require a lot of dedicated work. It's not going to be done by psychedelics. That healthcare providers really need to speak to injustices, including epistemic injustices in medical practice. They need to speak to the value of subjective experience. We really need to be looking more at patients as a whole, rather than just looking at what they reported on the iPad and the PHQ-9 when they're waiting in the office. So what I've described to you in this talk, and I'm getting close to wrapping up here, and then we can do some discussion, are really sort of two competing visions. And I don't think they have to be in competition. We can hopefully benefit from them dialectically. But I draw your attention to this article called The Psychedelic Divide by Marianne Apostolides. I always include this slide in my talks. She wrote this, I think it was published in early 2022, where she really outlines in a beautiful fashion sort of these two different visions for how psychedelics actually work, what they're all about, how we're going to employ them in our culture. And one is really a sort of top-down, more sort of objective science approach. The other is really more focused on direct personal experience. Like I said, this need not necessarily be clashing belief systems. These are really two different complementary ways of approaching a problem. Obviously, we've all benefited from Cartesian ways of looking at things. We have microwave ovens and I was going to say nuclear bombs, but that's not a benefit of physics. But really, there is a role for objectivity, and there is also a role for subjectivity. And these are two books that have examined sort of the interplay between the two in very nuanced fashion. One is by Alan Watts, who many of you are probably familiar with. It's a spiritual leader from the 50s, really through the 70s, wrote a number of short, very pithy books. This one, Psychotherapy East and West, essentially boils down to him describing how the fundamental goals of psychotherapy, as well as many contemplative practices from the East, are actually quite similar and the same, and can complement each other quite well. This book, Shadow Culture by Eugene Taylor, was written by a Harvard psychologist who passed away a few years ago. And the thesis of this book is examining how the prevailing sort of philosophical paradigm in the United States from its inception has always been a very sort of hierarchical, top-down way of thinking. And yet periodically there's always been this sort of shadow culture that will well up, that really is more sort of focused on subjective experience, on direct personal experience. And he traces it from the first and second Great Awakenings in the 17th and 18th centuries, all the way up into the counterculture of the 1960s, the New Age movements of the 1970s. And if it had been published today, I think he would include sort of psychedelic renaissance in that as well. So great books for those that are interested in further reading. That's all I have. I wanted to leave a little bit of time for questions, and I think we have 13 minutes, so I will stop. Whoa.
Thank you, Franklin. This was extremely good. So I think we'll just open it up. If anyone has a question they feel called to ask, just unmute, and we'll try to navigate.
Is my screen still shared? I'm trying to unshare
Oh,
it.
it is, yes.
There we go. Stop share.
We have someone, we have Lisa.
Somebody's waving. Hi.
I just want to tell you, your talk was absolutely riveting. I'm used to putting on webinars and just continuing to do my work and not really listening, but you completely grabbed me. I'm an anthropologist and I've just gotten IRB approval to do a study of psychedelic integration groups here in Birmingham. And I like what you're talking about is what are the vessels for holding these things? And they're going to probably take really different shapes in different local settings. And so one of the things I'm looking at here is how a therapist has put together a public integration group and is kind of doing that sort of thing locally. Anyway, you said that the blinding, like you can't have blinded studies. If you could just clarify for me why psychedelic studies can't be blinded.
Well, I think, what tends to happen is that people know if they've been given the psychedelic versus a placebo. And so a lot of studies have tried to get around this by delivering either a very small dose of the psychedelic that might, give some of the somatic effects, but not the psychological effects, to trick the patient. People have used niacin, which causes a lot of flushing. People have used Benadryl. I see Lindsay Owens on here. Hi, Lindsay. I know that Lindsay was involved in the NYU study, and I think you guys used Benadryl, right, as a placebo.
Yeah.
But I think in most studies, it's been shown that people can pretty easily figure out if they actually were given psilocybin, obviously being the most common, as opposed to placebo. Now, one thing I left out here is that amidst all the criticism of the failure of blinding in psychedelic work, the blinding in many conventional psychopharmacological studies also tends to not be as good as we think it is. So, there's a lot of other kind of angles to this. But I think with psychedelics, it's pretty hard to fool people into thinking that they got a placebo when they were given a psychedelic. We haven't solved that yet.
I have a question. I'll see if I can piece it together on the fly. I thought some of what your discussion about epistemic injustice was really interesting. And I think one of the things that concerns me a lot about medicalization is, as you said, there's sort of this like flip where it's like we're trying to cram this into our model and make our model stretch to, instead of making our models stretch to accommodate it as it is, we're trying to find shorter acting psychedelics, non-psychedelic psychedelics. And in a lot of ways, it actually kind of feels like a metaphor for or a recipe for like a bad trip. It's just like trying to control everything and trying to make it turn out your way, but that's just not really the lesson there. And so the other thing is people have experiences that challenge like fundamental ontological assumptions of the systems that they're having the experiences in. And so if you're having experiences that are blowing the container that you're having them in, then the container is probably not very good to begin with. And so I guess what I'm wondering is, how do you see like an effective medicalization that actually does have some flexibility and space to sort of hold all these like kind of radical shifts in worldview people might have, rather than trying to just fit it into how we understand mental health and mental illness?
Yeah, I mean, I guess the first thing I do want to say is, I mean, I'm not opposed to research on 5-HT2A receptor agonists that don't have a psychedelic effect or relate to any. I mean, research is always good, but the question is, why are we so focused? It seems it's just like there's a great deal of money focused solely on researching compounds, rather than just sort of chasing the fact that the psychedelics that we already have, that because they're unpatentable, actually on a systems level would be far cheaper to sort of disseminate once things get approved by the FDA. Why are we not sort of wholeheartedly focusing on the things that exist now that we already have evidence for? Why are we chasing novelty at this early stage of the game? You know, and in terms of the rest of what you said, I think that probably most of the people who are going to be best suited, truly best suited to be guides and to hold containers for participants are not necessarily going to be people that are highly trained psychiatrists, you know, people with PhDs, you know, for the reasons that you articulated. I mean, certainly you don't get any philosophy in medical school. And so when somebody has this totally worldview shifting experience, I don't know that you know, the people like us who are psychiatric trainees are really best suited for that sort of work. I mean, in and of itself. And so I think it's sort of ironic that the FDA tends to be mandating, you know, you have to have sort of like a PhD psychologist and an MD psychiatrist, you know, being the therapist in a lot of these protocols, when really these are probably not the people that are best suited. I mean, probably people more that are pastoral care counselors, hospital chaplains. I think just by dint of the type of work they do are probably better suited. But you know, this will all, you know, eventually we'll study this and figure this stuff out. But yeah.
Go ahead, Ken.
Oh, hi there. Can I unmute my video, Daniel, or open up the video?
Yep, go ahead.
Okay. Anyway, oh, hold on one second. Sorry about that, people. Outstanding talk. And I mean, obviously a lot to digest there. I'm a primary care physician also in Boston, by the way. So good to meet you, Franklin. My name's Ken Grossman. You articulated a lot of the potential or future problems, of course, with the development of psychedelic medications, their application, et cetera. And, you know, I would be curious what you say about sort of, you know, we're at that crux right now, really, where things need to start to change. And what 2 or 3 or 4 things would you change if you had the power, you know, in the next couple of years to change? That's part one of my question. Part two is I just, because there's a lot of future healthcare practitioners on the call, I just wanted to clarify something that to me sounded nuanced, but it may have been heard in a way that I think you probably didn't mean. And, you know, one of the things you said on one of your earlier slides was that more and more treatments, but people aren't getting healthier. And, you know, and I think that that's true up to a point. Obviously, as a primary care physician, I see treatments that work all the time, you know, and, you know, for example, just take some of the antihypertensives that we use, which clearly reduce risk of stroke, heart attack, and renal failure. So those are really important medications that are of benefit. And even in mental health, you know, although again, the pharmacology of mental health is incredibly complicated and we don't have very great tools, some of the tools we have in some people work brilliantly, right? And again, it's not to negate all the other aspects of the human experience that you brought up, but I just don't want people to feel nihilistic after hearing what you said. Yep. And I'm sure you didn't mean it like that. So I'll leave that question, and then that was a comment.
Yeah, no, absolutely. I am not trying to transmit a message of nihilism. You know, I mean, I would mention, just as an aside, because I just think this is the most amazing thing. One of my best friends is a neurosurgery resident, but he also is running a lab simultaneously. And he works on Canavan disease, which is a disease that is usually fatal. You know, babies usually die at the age of 1 or 2 and never live any longer. And he's working on a viral vector delivered gene therapy. And, you know, they're having children actually walking with this treatment. And it's just like so amazing. So that's just one of many examples that, you know, contemporarily there is a lot of innovation, and obviously there is a huge number of patients that are helped by medical care. I mean, I am a practicing psychiatrist and I believe in the work that I do. But I think that where we go wrong is that, we don't necessarily look at, which treatments are necessary for which patients, and the amount of treatment on average seems to be outstripping the amount of benefit, at least in this country. In terms of what could be done, I think one of the issues, I mean, this gets into this, what Macmillan talks about in his paper on epistemic injustice and psychedelic research. One of the problems is really just that psychedelics remain illegal. And so that most of the people that do have a lot of experience with them, and this is not, I want to be very clear here that I am not endorsing or advocating underground work in any fashion. However, be that as it may, there are vast numbers of people that have extensive experience with psychedelics who cannot come forward, or who no researcher in their right mind would ever publicly say that they approached and asked them for, hey, how should we work with these? And I think that's a huge problem, just because there's this huge untapped reservoir of potential information. Not all of it good, not all of it valid, but there is information and know-how and knowledge that our field just can't access. So I think if we could address the legal challenge so that we could more openly consult with practitioners, and particularly Indigenous voices who have millennia of community level experience working with these as tools and agents, I think that would do a great deal of help for sort of making this a more honest profession, because we're sort of, the overall profession is acting as if psychedelics are brand new, and we're sort of creating all this knowledge de novo, but that's completely not what's happening, or that's not the actual reality. So that's one thing that comes to mind. Thanks for pointing out the anti-nihilistic bent.
I just as a follow-on question though, Franklin, I mean, I read Michael Pollan's book in which he talked about his own, I'm trying to remember, I think it was a peyote experience. And it was very hard for him to crack the nut of being allowed to do it with Indigenous people in an Indigenous setting, because he was an outsider, a man of Western education, et cetera. So although your hope is that we could learn a lot from these practitioners, again, this is I'm totally naive about this, other than that experience of Michael Pollan, where it was really a hard thing to do. We eventually did it. Is it going to be easy? Is it going to be doable? Do people want their practices brought to the Western world?
I think it's always, I mean, I don't have an answer to that at all. And I wouldn't, as, just some white guy, want to presume to have the answer to that question. I think the simple thing with a question like that is always probably just to ask the person. And I'm sure different practitioners have different attitudes, and trying as best one can when asking such questions of also being mindful of power dynamics that exists, because there obviously is a lot of psychedelic tourism, and the economic lopsidedness of people seeking it versus people administering it does definitely sort of create a distorting power dynamic. But I'm not an expert on this. I included that information because I think it's important, but Eduardo Schenberg, Schenberg, gives some fantastic talks and has written extensively on this. You can look him up on Twitter and then kind of find all of his work.
Great, thank you. Great talk, just outstanding and mind-opening.
Yeah.
Thanks so much.
Thank you everyone for coming on. I just want to respect everyone's time. This was truly a really great event. Fascinating, I think everyone would agree. Thank you, Dr. King. Thank you, Franklin, for coming on and talking to us. And check back in for future PSF events, because we have one more coming up this event.
Yeah.
This semester.
We have Kelly O'Donnell from NYU's psychedelic research group coming next month. So info will go out soon. Thanks,
Cool.
everyone. Thank you,
Thanks
Franklin.
for coming. Thanks for inviting me.
Of course. It was a pleasure. Take care. Have a great day.
Bye.